Bismillahirrahmanirrahim. In our previous lecture, we discussed an introduction to the thyroid gland and thyroid hormones. And we discussed the synthesis, storage, secretion, and effects of the thyroid hormones on various body tissues. Today, we start with abnormalities of the thyroid hormones and thyroid gland. For any endocrine gland, we discuss abnormalities either in the form of change in the size of the gland, which if enlarged may produce the mass effects, and the functional abnormalities in which there is over-secretion or under-secretion of the hormone occurs from the endocrine gland with its resulting consequences. So the thyroid gland may be a hyper-functioning thyroid gland in which there is excess secretion of the thyroid hormones, and there may be under secretion of the thyroid hormones that result in hypothyroidism. And the third abnormality of the thyroid gland is in the form of the various tumors and neoplasms that happen in the thyroid gland. The hyperthyroidism is a condition in which the thyroid gland is producing excess thyroid hormones. And we know that the thyroid hormones are very important because they accelerate the basal metabolic rate. The hyperthyroidism, in which there is excess secretion of the thyroid hormones, may be in the form of overt hyperthyroidism or subclinical hyperthyroidism. In subclinical condition, the patient is having the disease, but the patient is not having the symptoms. And this patient with the subclinical disease is at risk of developing into an overt disease, in which the disease, full-fledged disease, occurs with all of its symptoms. Normally, we measure the function of the thyroid gland and secretion of the thyroid hormones by doing the first line test, that is the TSH. We know that TSH secreted by the anterior pituitary gland controls the function of the thyroid gland. So when the thyroid hormones are less, there occurs an increase in the TSH, and we say that the patient is hypothyroid. While the excess secretion of TSH and its high level in the blood presents overt hypothyroidism. For example, in the subclinical hypothyroidism, we take the upper level of the TSH as 10 milli-international units per liter, while its reference range is up to 4.5 milli-international units per liter. If it is 10, this is overt hypothyroidism, without any doubt. But sometimes the TSH level may be between 4.5 and 10 milli-international units per liter. And in this situation, though the patient is having elevated TSH level, but the patient is not having symptoms, and we say this condition is the subclinical condition or subclinical hypothyroidism. Now, the two conditions here that I want to mention is the thyrotoxicosis and the hyperthyroidism. And my students must differentiate thyrotoxicosis from hyperthyroidism. Thyrotoxicosis itself is a hypermetabolic state which is caused by elevated circulating levels of the thyroid hormones. But if these thyroid hormones come from an overactive thyroid gland, then this is hyperthyroidism. And if the hormones are coming from somewhere else, from any other source, then do they have caused thyrotoxicosis? The patient is thyrotoxic with a hypermetabolic state, but in this situation, the thyroid gland is normal and it is not producing excess thyroid hormones, but the thyroid hormones are coming from some other source. There is thyrotoxicosis, but no hyperthyroidism. So, hyperthyroidism is the most common and important cause of thyrotoxicosis, but thyrotoxicosis may occur without hyperthyroidism. For example, if a patient takes synthetic thyroid hormones in the form of tablets, and if he goes into a hypermetabolic state, into a state of thyrotoxicosis, but he is not suffering from hyperthyroidism. Now, about hyperthyroidism, the common questions are the causes of hyperthyroidism, various pathological changes that are caused by excess secretion of thyroid hormones and sometimes due to the enlarged thyroid gland known as the goiter having their mass effects, the signs, symptoms, and the various investigations that we do for thyroid diseases and the lab diagnosis, particularly the measurement of T3, T4, and TSH, and sometimes the question asked is about the treatment. Now, as I mentioned, that thyrotoxicosis may or may not be associated with hyperthyroidism, and hyperthyroidism is the most common cause of thyrotoxicosis. However, there are certain conditions in which thyrotoxicosis occurs without hyperthyroidism. Now, coming to the hyperthyroidism, hyperthyroidism may be primary. The problem lies in the thyroid gland, or it may be secondary. In primary hyperthyroidism, the most common causes are the Graves' disease, which is an autoimmune disease and that we are going to discuss a little in detail. Primary hyperthyroidism may also be caused by multinodular goiter, in which a goiter of the thyroid gland becomes toxic and hyperfunctioning. Adenoma, which is a benign tumor, may become toxic and may secrete excess amounts of thyroid hormones causing thyrotoxicosis, and sometimes excess iodine intake may result in growth and oversecretion of the thyroid gland causing hyperthyroidism. The secondary hyperthyroidism, in which the problem doesn't lie in the thyroid gland, but we know that the thyroid gland is controlled by the anterior pituitary gland through the thyroid stimulating hormone, which itself is under the control of hypothalamus through thyrotropin releasing factor or thyrotropin releasing hormone. So, if there is excess secretion of thyroid stimulating hormone from a pituitary adenoma, a hyperfunctioning benign tumor of the pituitary gland, so it will cause hyperthyroidism, but this is secondary because the problem lies in the pituitary gland and not in the thyroid gland. The conditions which are not associated with hyperthyroidism but still thyrotoxicosis occurs include various uh, different types of infections that occur in the thyroid gland causing its inflammation. The two most important are the granulomatous inflammation and the lymphocytic inflammation. In granulomatous inflammation, it is just like granulomatous disease, and it is mostly painful, while lymphocytic thyroiditis, which mostly occurs in female after childbirth or delivery, it is painless. In these two conditions, there is no excess production of the thyroid hormones, but the thyroid hormones already present in the colloid, in the thyroglobulin, in the lumen of the thyroid follicles. It is secreted in excess amount than normal, and the patient have a high circulating level of the thyroid hormones, but it is not associated with excess production of the thyroid hormones by the thyroid gland or hyperthyroidism. But this is the due to the release of preformed hormones that are present in the thyroglobulin or in the colloid. The struma overi is a condition which is characterized by the development of the teratoma, a tumor in the ovaries, and since this teratoma is derived from any of the three germ layers, the ectoderm, endoderm, mesoderm, and sometimes this teratoma contains the thyroid tissue, and this thyroid tissue may produce excess amounts of the thyroid hormones. Here again we can see that there is excess circulating thyroid hormones in the blood, but it is not coming from the thyroid gland, and this is due to the ectopic secretion by an ovarian teratoma. Sometimes factitious thyrotoxicosis may occur if a patient of, suppose a patient of hypothyroidism, if he takes instead of advised 1 or 2 tablets, if he takes 8 and 10 tablets at a time, or a patient who is not hypothyroid, if he accidentally takes thyroxine, he may develop thyrotoxicosis. But here again the source is not the thyroid gland, but it is exogenous thyroxine. The primary causes of the hyperthyroidism include the autoimmune Graves' disease, toxic nodular goiter, toxic hyperfunctional thyroid adenoma, and if the gland becomes damaged or inflamed, as I mentioned, like in granulomatous thyroiditis or lymphocytic thyroiditis, in which there is release of preformed thyroid hormones. Thyrotoxicosis may sometimes occur due to excess iodine induced, when we know that iodine is essential for the formation of the thyroid hormones. But very important is a condition of neonatal hyperthyroidism, and this neonatal hyperthyroidism occurs in the newborn where the mother suffers from Graves' disease. And in Graves' disease, there is secretion of excess thyroid hormones. And the antibodies that simulate the thyroid stimulating hormone cause stimulate the thyroid gland to produce excess thyroid hormones, and these antibodies can cross the placenta and enter into the blood of the neonate and cause hyperthyroidism or thyrotoxicosis. Here again the problem is in the mother, and these are the immunoglobulins or TSH simulating antibodies of the mother that crosses the placenta and cause neonatal hyperthyroidism. But once the baby is born, these antibodies are cleared and the condition returns to normal. Now, Graves' disease is really an autoimmune disease, and we know that in any autoimmune disease, our immune system produces and reacts against our own body proteins. So in Graves' disease, the immune system reacts against the thyroid proteins, and they consider the thyroid follicular cells as being foreign. The antigen presenting cells like macrophages, they engulf the antigen and present it to the T cells. The T lymphocytes then stimulate the B lymphocytes, which are converted into plasma cells, and they produce antibodies against the thyroid proteins. And the most important antibody that the B cell produce against the thyroid proteins is the TSH receptor antibodies. And these antibodies bind to the TSH receptor on the thyroid gland, which normally binds the TSH that is released from the anterior pituitary thyrotrope cells. But here, the antibody behaves just like thyroid stimulating hormone. It binds to the TSH receptor of the thyroid gland and causes growth and uncontrolled secretion of the thyroid hormones. Three types of antibodies are produced, but the two very important are the TSH receptor antibodies, because they mimic TSH and stimulate the gland to cause oversecretion of the thyroid hormones, and the thyroid growth stimulating antibodies, which induces growth and proliferation of the thyroid follicular cells. One form of the antibodies is known as the TSH inhibiting antibodies, and they inhibit the TSH from binding to its receptor. But the main problem is caused by the TSH receptor antibodies and thyroid growth stimulating antibodies. This type of disease is more common in female, usually in the 20 to 40 years of age. There is a component of genetic susceptibility, and the disease may run in families. And as is true about all autoimmune diseases, when a person suffers from one autoimmune disease, we search for the presence of another autoimmune disease. Because any autoimmune disease in a person is an indication that we must search for other autoimmune diseases in that person too also. The Graves' disease have a special triad. Hyperthyroidism will cause thyrotoxicosis, and it may cause the enlarged hyperfunctional thyroid gland in which there is diffuse enlargement. Graves' disease, the second component of the triad, is the exophthalmos or infiltrative ophthalmopathy that we discuss next in detail. And the third component is the pretibial myxedema or dermopathy, which may occur in a minority of the cases. So, in Graves' disease, the B lymphocytes produce antibodies, and these antibodies, they imitate or simulate the thyroid stimulating hormones and stimulate the thyroid follicular cells to cause excess T3 and T4 production, which may lead to hyperthyroidism. But additionally, these antibodies cause hyperplasia, increase in the number of cells, and hypertrophy, increase in the size of the cells of the thyroid follicular cells as well as the interstitial tissue, the tissue in between the follicular cells, and may cause enlargement of the thyroid, and the thyroid gland is converted into a goiter, which is a mass in the anterior part of the neck, which may sometimes be very clearly visible and palpable, and which may cause disfiguration of the person's neck. The TSH stimulating antibodies may cause the follicular cells to express molecules that may call the T lymphocytes, and the infiltration of T lymphocytes will cause a state of inflammation, and these infiltrations are commonly seen in the interstitium, the tissue in between the thyroid follicles. So the triad of the Graves' disease is hyperthyroidism, excess secretion of the T3 and T4 under the effect of the TSH stimulating antibodies. But these TSH stimulating antibodies also activate fibroblasts, the cells that are involved in healing and repair. And these fibroblasts are stimulated by these antibodies, and they proliferate and synthesize extracellular matrix proteins, particularly the glycosaminoglycans. But here we take two very important sites in the body, and one is the tissue around the eyes, where the excess production of the extracellular matrix protein and glycosaminoglycans will occur, and it will cause local inflammation and swelling. And this will appear in the form of overbulging of the eyeball known as the exophthalmos. And this component of the triad is known as the Graves ophthalmopathy. The inflammation and swelling under the TSH stimulating antibodies may also weaken the muscles that control the movement of the eye and the upper eyelid, which usually clears and cleans the eye. And the eye becomes dry due to weakening of the muscles that control the movement of the upper eyelid. And a dry eye has increased risk of corneal damage and corneal ulcers. The third component of the triad is the thickening of the skin, and this is particularly prominent at the anterior border of the tibia, known as the pretibial myxedema, where the skin becomes thickened and the persons develop non-pitting edema, and this skin is also at high risk of infections, and sometimes serious and complications may occur due to the presence of the Graves dermopathy. So the three components of the Graves triad are hyperthyroidism, Graves ophthalmopathy, and Graves dermopathy. In this picture, we can see the ophthalmopathy with the eyes being bulged out due to the accumulation of the extracellular matrix proteins behind the eyes in the eyeball. And in this picture, we can see the thickening and non-pitting edema of the Graves dermopathy. So the triad consists of hyperthyroidism due to TSH stimulating antibodies that stimulate the thyroid gland to produce thyroid hormones, and also cause hypertrophy and hyperplasia of the gland, which may result in the formation of an enlarged thyroid gland or goiter. The person suffers from weight loss despite of increased appetite. Why? Because the basal metabolic rate is high and the carbohydrates, fats, and proteins are rapidly uh, broken down, and the patient suffers from weight loss. Due to excess production of heat, the person suffers from heat intolerance. This is also associated with high basal metabolic rate. And as a result of increased and high basal metabolic rate, the person may suffer from increased heart rate in the form of tachycardia, excessive sweating, even in the months of uh, severe cold. Even in December, January, and February, the hyperthyroidism, the patient with hyperthyroidism feels hot, warm, and he may suffer from sweating. Due to stimulation of the autonomic nervous system, the person is hyperactive, very alert, and want to do something. The patient is tired but he cannot sleep due to activation of the autonomic nervous system. And this patient also appears anxious. The second component of the gravis ophthalmopathy, gravis triad of symptoms is the gravis ophthalmopathy resulting in exophthalmos and gravis dermopathy resulting in the pretibial myxedema. Feeling warm, shortness of breath due to increased respiratory rate, decreased strength of the muscles, female with menstrual disturbances, loss of weight, tachycardia, increased gastrointestinal motility resulting in diarrhea, and psychological problems like anxiety and restlessness. Thyroid storm is a very serious complication of Graves' disease, and it particularly occurs in those people who are taking anti-thyroid drugs but they stop taking the anti-thyroid drugs suddenly for days. And in this condition, there is acute elevation of the catecholamine levels, adrenaline and noradrenaline. And as we know that thyroid hormones make the central nervous system and cardiovascular system very sensitive. They increase the sensitivity of the CVS and CNS to the effects of catecholamine, adrenaline, and noradrenaline. This type of situation may also occur in conditions of stress like infection. If the patient undergoes some sort of surgery or any sort of stress, he may develop thyroid storm. And the excess production of the catecholamine and increased sensitivity of the CVS and CNS to the catecholamines result in severe hyperthyroidism, and it mostly develops in patients of the Graves' disease, and that is a medical emergency. There is very exaggerated signs and symptoms of hyperthyroidism, and the patient may suffer from severe tachycardia, increased heart rate, severe sweating, temperature which is turned into fever, and other symptoms of the hyperthyroidism are so much exaggerated that particularly the very increased heart rate may result in cardiac arrhythmias and this may lead to fibrillation. Diagnosis of the Graves' disease is made by measuring the thyroid profile, which includes measurement of the TSH, free T3 and free T4. Mostly the free T3 is elevated, free T4 may also be elevated, and the TSH is suppressed, and sometimes even it may be undetectable. For the confirmation of the Graves' disease, we search and we detect the TSH antibodies, and the presence of the TSH antibodies may confirm the diagnosis of Graves' disease as the cause of hyperthyroidism. Sometimes we may use radioiodine scans in which we give radioactive iodine to the person, and we know that radioactive iodine is taken by the thyroid gland, and then we take images, and we come to know that either there is diffuse infiltration of the thyroid gland, or if there is a single hyperfunctioning multinodular goiter, or if there is an adenoma and other conditions that may appear on radioactive iodine scans. For the treatment, we give beta blockers to control the symptoms, particularly those caused by the catecholamines, adrenaline, and noradrenalines. We give anti-thyroid drugs if the problem is due to hyperthyroidism and thyroid gland, and these drugs include thionamides that will work at the level of the by inhibiting the oxidation of iodide to iodine, and also may inhibit the coupling of MIT and DIT to form thyroid hormones. And radioactive iodine is just like giving poison in food, because the thyroid gland doesn't know that the iodine that the gland is taking is radioactive, and the radioactivity will destroy the thyroid gland, and it may cause partial or complete destruction of the thyroid gland with the cessation of the symptoms of hyperthyroidism. And now this patient will go into a state of hypothyroidism, and if there is complete destruction of the gland, the patient may suffer from hypothyroidism lifetime, and then the patient is supposed to take thyroxine for the lifetime. Sometimes if there is an enlarged thyroid gland, and uh, if we consider that the enlarged thyroid gland at goiter must be removed, so surgery may help us in this situation. Thank you very much.